All right. This one is ventricular rhythms. So we're going to talk about ventricular rhythms and where they start from. We're going to talk about PVCs. We're going to explain idioventricular rhythms, and idio means I don't know, and ventricle means from the ventricle. So I don't know where they come from in the ventricles and what those look like on an EKG. We're going to differentiate between idioventricular and accelerated. We're going to look at VTach and what it looks like on an EKG, VFib, and ventricular asystole. So if your ventricles stop working but your atria are still working, you'll just have a rhythm of P waves. We're also going to start talking about PEA and what to do for all of those things. Remember, rhythms are classified where they start. The SA node is supposed to be the head honcho. Sometimes it fails, and then the AV junction fails. So if all of this fails, then the ventricles will be like, fine, I'll do it. Rhythms that are initiated anywhere in the ventricles are called ventricular rhythms. They're the least efficient. Now your atria, remember, your ventricles are normally gravity fed. Your atria are just contract to top them off. But when your ventricles are having to do the work, even though they're doing the work of a factory that technically is operating at like 75% capacity, they're usually fast, so they don't have time to fill up all the way, so your cardiac output is decreased, or they're weak and they can't make an effective contraction to send blood around and around. This is how it should work. Your SA node fires, goes down through your atria on both sides, then hits your AV node, goes through the right and left bundle branches and into your Purkinje network. And that's what these slides show. Remember, SA node goes 60 to 100, then this transfers the pulse all the way across both atria. It hits the AV junction, it slows it down, goes 40 to 60, then it goes through the right and left bundle branches, and then your Purkinje network, the firing rate for it is 20 to 40. So those are our intrinsic rates for them. Ventricular rhythms always obviously originate in the ventricular musculature, and they can travel backwards, so you may have all kind of wide, bizarre deflections from your isoelectric line. However these impulses travel, it's not normal. Because it's going through time on your EKG paper, when they bypass their normal pathway, your QRS is going to widen. So instead of being the 3 baby boxes wide, you're going to get very wide, elongated complexes, because remember, your EKG paper travels 25 millimeters per second. This impulse is going through there longer, so instead of being nice and tight and narrow, that QRS is going to widen out. You may have P waves, but usually you can't see them because they're in this wide, bizarre QRS complex. PVCs, premature ventricular complexes. Remember, anything premature or ectopic it's a one-time thing, sort of, and it's just out of place. It comes before the next expected complex. It's a grouchy site in the ventricle, just a little crybaby that's like, hey, I want to do something too. So it fires off an impulse, and the result is a PVC. Now, one every now and then is not that big of a deal, but they can become more frequent. They can also not produce a pulse. So the underlying cadence of the SA node is not interrupted by a PVC or the SA node depolarized, so you'll have a sinus rhythm, and then you'll have your PVC, and then it's followed by a compensatory pause, and then it comes back to the normal sinus rhythm or whatever the underlying rhythm is. So here we see that. So we have P, QRS, and then your ventricle is like, I want to play this game. So it makes one, and the QRS is like super wide, and then it has a little pause, and then it makes a normal complex, and another normal complex, and then another PVC that's wide and bizarre, and then normal, normal, normal. So these two right here, this one and this one, are your PVCs. They can fall between two sinus beats without interfering. This is referred to as interpolated beat. So you'll have a normal beat, then a PVC, then a normal beat, then a PVC. They may appear in patterns, different shapes. The shape is what we refer to as morphology. It's better if they're all the same shape. If they're all different shapes, then this is more irritability in your heart. When it's every third beat, it's called, or I'm sorry, every other beat is called bigeminy. Every third beat is trigeminy. Every fourth beat is quadrigeminy. If you have two in a row, it's called a couplet or repetitive. If you have three or more in a row, it's called B-tech or a run of B-tech. So here we have a normal sinus, well, a sinus rhythm that's got elevated ST there because this doesn't come back to the isoelectric run. So we have two beats that are normal, and then this wide bizarre complex, which is the PVC, and then four that are normal, and then another PVC. This PVC and this PVC look exactly the same. We call this unifocal, one foci, one shape. Now we have this rhythm here. This is a PVC, it's wide and bizarre. Then we have a normal sinus beat, another PVC, but this PVC does not look like this PVC. Then we have three sinus beats, and then another PVC that doesn't look like this one or this one, and then a normal beat. So these three PVCs are all different shapes or morphologies, so we call it multifocal. Because this went off from one site in the ventricles, this went off from a different one, and this went off from a third one. PVCs are just a sign of irritability in the ventricles. So multifocal PVCs are more serious than unifocal PVCs and indicate greater irritability. So these people need to go to the hospital. They need to be evaluated to figure out what's causing this. These are, this is a rhythm of bigeminy. So you have normal and then a PVC, normal, PVC, and it's every other beat except for this right here. So this is bigeminy, and then you have two together, and that's a couplet. This is regular bigeminy, so you have a normal beat, wide, bizarre, PVC, normal beat, wide, bizarre, normal beat, wide, bizarre, so that's bigeminy. This one shows you trigeminy, so you have every 1, 2, 3rd beat is a PVC, 1, 2, 3rd beat is a PVC. Idioventricular rhythms. These are ventricular escape rhythms because it's the heart is trying to find an escape from the SA node failing to fire. The last ditch effort to keep you alive. The SA node, the AB node have failed. The rate's usually less than 40, and the cardiac output is severely decreased. And then an agonal rhythm is where that rhythm falls below 20. You are dying if you have this, unless something is done right now to figure out the cause and reverse it. This is the last rhythm, or last semblance of a heart rhythm. A lot of times you get this after defibrillations. A lot of heart damage, usually the result of an MI, or the failure of all your higher pacemakers, SA node, AB node, anywhere in the ventricles. Your heart muscle is literally dying. This is a lethal rhythm, and you have to treat it quickly. So idioventricular, rates 20 to 40. There's no atrial rhythm. Ventricular rhythm is usually regular. No P waves, no PR interval. You have QRSs, but they're big and wide, greater than that 3 baby boxes. Accelerated idioventricular just means we have a rate that exceeds 40. So 40 to 100 is considered that. Like junctional, we exceeded the intrinsic rate of the junctional rhythm. So between 60 and 100 is accelerated junctional. Between 40 and 100 is accelerated idioventricular. There's no P waves, no PR intervals. And it looks like this. So we have a rate of 1, 2, 3, 4, 5, 6. So 60, that's greater than 40. No P waves. It is wide and bizarre. This is accelerated idioventricular. This occurs whenever your heart is starved for oxygen. Can be mistaken for VTach, but technically it's not ventricular tachycardia because it's not fast enough. Once it crosses 100, then it's considered ventricular tachycardia. Look at your patient. They probably look sick and they need some treatment. ventricular tachycardia rhythms. This is when the rhythm is 3 or more PVCs, and the rate is greater than 100. So it's just back-to-back PVCs. Normally overrides the normal pacemaker of the heart. It often occurs rapidly and it is initiated by a couple of PVCs that occur, and then they just keep getting more and more until you degrade into this rhythm. If it's sustained, the patient's clinical condition may rapidly deteriorate. And sustained means it's lasted for more than 30 seconds. If it's less, it's non-sustained VTAC or simply a run of VTAC. And this is what it looks like. So nothing is happening here. Nothing is happening here. Your ventricles are firing. So just down here is working, but they're going so fast that they don't have time to refill. Now, if it wasn't too fast and your heart was beating efficiently and strongly, then this would be a viable rhythm. Now, VTAC can occur with a pulse or without a pulse. And this rhythm is 1, 2, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 180. This is too fast for your ventricles to properly refill and push blood out to your body, namely your brain and lungs, for you to sustain this for any length of time. Now, people have been in VTAC for hours and been okay, but this is not, you can't just be in this for like a life. To be classified, it's either pulseless VTAC or VTAC with a pulse. So this can produce a pulse. If it's pulseless VTAC, immediate defibrillation or electricity should be applied. VTAC with a pulse, you gotta look at your patient. Typically, I've seen patients look completely fine with this, and you put them on the monitor and you're like, look at what we got here. But most of the time, they are unstable. They have shortness of breath, chest pain, low blood pressure. These are cardioversion cases, and they need immediate electricity. If the patient is hemodynamically stable, their blood pressure is normal, they don't have chest pain, they're just like, I don't feel good, I don't know what's wrong, then we're going to use drugs for them, and we'll go over the drugs later. Causes, usually this is the cause, myocardial ischemia or an infarct is occurring, hypoxia, electrolyte imbalances, anxiety, physical exertion, heart disease. Sorry. These are the rules for it. Rates 100 to 250. There's no atrial rate because you can't discern P waves. It's usually regular. P wave before each QRS may be present or absent, but they're not associated with QRS complexes. There's no PR interval. The QRSs look alike except for in a torsades, which we'll talk about in just a second. But there's a bizarre QRS morphology. It's stretched out in greater than 0.12 seconds or 3 little boxes. Torsades is very similar to VTAC. The QRSs all kind of look different, and torsades, the points means turning of the points. So it looks like you're taking the rhythm and having it like this, and then like this, then like this, then like this. So it's kind of twisting. A lot of times it's a result of low potassium or low magnesium. It could be TCA overdoses, use of antidisrhythmics, or a combination of all of this. And so you'll have it look like this. So it goes down, 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 up, 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 down, 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 down. The treatment for this is still, in ACLS, it's still the VTAC algorithm, but you're going to add in magnesium sulfate if it's because of hypomagnesia. But you still have to treat this as a VTAC rhythm. So you use magnesium as your drug of choice, but you're also still doing all of your other ACLS things. VFib, fatal dysrhythmia, you're definitely without a pulse with this. It's the most frequent rhythm occurrence in sudden cardiac arrest. Now, if they've been down, they're most likely asystole or PEA. It tends to occur within an acute MI. And these are all of your foci in the heart cannot produce, they're too ischemic to be able to produce an impulse. The myocardial cells just basically quiver and weakly depolarize rather than doing a coordinated contraction. They're initiated by multiple ventricular impulses that are not transmitted through any normal path of conduction. They're disorganized, rapid, irregular waves, looks chaotic, nothing is organized, death will occur. You can have fine VFib, which is less than 3 millimeters of amplitude or 3 boxes, or coarse, which is greater than 3. Coarse VFib is generally more irregular than fine VFib. Patient assessment, make sure your leads aren't loose, make sure that's not artifact, look at your patient, not the monitor. These are the causes: a heart attack, lack of oxygen, drug toxicity, overdose, hypoxia, all of that. We just went through the rules. This is fine VFib. It's not, the amplitude from here to here is no bigger than 3 boxes. And then this is coarse VFib. Ventricular asystole is there's no ventricle activity at all. It's also called cardiac standstill or asystole. It's represented by a flat line in the absence of any electrical activity. It may be difficult to distinguish from fine VFib, but you just flip over to lead 1 or 3 and look at it again. And if it is chaotic, then we're going to call it VFib. If it's flat, then we call it asystole. This is what happens when your heart's completely done. Can be caused by all of these: MI, cardiac trauma, aneurysm, heart blocks. Nothing is happening. Asystole. PEA, the absence of a palpable pulse and myocardial activity with presence of organized electrical activity. So, to break this down, it just means there isn't a pulse, but there looks like a rhythm on the monitor, but the patient's essentially pulseless. What we see on our monitor is a representation of the molecules crossing cell membranes and impulses in the heart. That doesn't always mean there's enough calcium in the heart to produce a contraction. It used to be called EMD, electromechanical dissociation, or the electricity and the mechanical action of pumping disassociated. Causes all of this: hypovolemia, heart attack damage, your heart exploded, a pulmonary embolism, horrid acidosis, a tamponade, that's going to usually be from trauma. You were really cold, you were really hot, you took drugs, your calcium was low, it was really high. Or a tension pneumo, where your lungs filled up with outside air until it squished the heart down so much that it cannot pump anymore. Clinical significance of all of our ventricular dysrhythmias: PVCs, not that big of a deal. Older people, it's very, very, very common. Even younger people that have increased intake of caffeine or stress or anxiety, these can all cause PVCs. Cardiac output may be compromised if they're frequent. So if they're having more than 6 a minute, this is considered frequent. And a lot of times you can just put some oxygen on them and those PVCs will go away. Idioventricular, most of these people are going to be symptomatic because their heart rate is lower, their output's lower. This causes weakness, dizziness, hypotensions, altered mental status, all of that good stuff. This is why we research these and try and figure out why they're happening and a fix for them. VTAC could be perfusing or non-perfusing. So these patients can be alive or dead at the moment because the rate is rapid. Ventricles don't have time to refill, so that makes the cardiac output drop. Treatment is based on whether or not you have a pulse in the clinical picture. If they do have a pulse, then you have to look at them a little harder, and are they stable or unstable? Do they require drugs or electricity? If it is perfusing and stable, O2, IV, and drugs. If they are unstable, we go straight to electricity. VTAC without a pulse, this is your ACLS pulseless algorithm. Immediate unsynchronized cardioversion, I had to read that, which is defibrillation. I don't know why they put it that way, but it's treated the same exact way as VFib. Aggressive, immediate treatment, or they're going to die. If there's no cardiac output, there's no perfusion. For VFib, and your heart's just kind of quivering there, nothing is producing a mechanical contraction. Nothing is producing a pulse, so this is an immediate defibrillation, CPR, airway control, IV line, and drugs. Clinical significance of asystole. This is where you'd see no electrical activity. Check in another lead to make sure it's not VFib. Treatment, CPR, IV, endotracheal intubation, and regular ACLS drugs. We're going to look at these strips. This is VFib, greater than, of course, VFib, greater than 3 millimeters of elevation. Organized, unorganized, and chaotic. This is fine VFib. It's smaller. No electrical activity, asystole. This is ventricular systole. Notice there's only little P waves here. Ventricles are not working. This rate is over 100. There's no discernible P waves. QRSs are wide. So this is going to be VTAC. This is normal sinus rhythm with PVCs, and it's every 4th beat, so that's quadrigeminy. This is a sinus rhythm with couplets of PVCs. This is a sinus rhythm. This is a sinus beat, and so are these, but these PVCs look different, so these are multifocal PVCs. Same thing, sinus beats. These look the same, so the morphology is the same. So those are a sinus rhythm with unifocal PVCs. This is very obvious. It's a VTAC rhythm, and it switches deflection or from the isoelectricon. So this is torsades. This rate is clearly over 100, no P waves. QRS is wide and bizarre. This is VTAC. This is sinus rhythm. That's a T wave. P, QRST, PVC, P, QRST, P, QRST, PVC. So I don't know. We don't see the whole rhythm to confirm it, but I would suspect there would be a PVC right here, and it would be called trigeminy. But as it sits now, we just have a sinus rhythm with 2 PVCs. This is bigeminal, so you have a normal beat here, followed by PVC, normal, PVC. This is bigeminal PVCs. This is a wide, now if these QRSs were skinny, this would be junctional, but they are wide and bizarre, no P waves, so this is idioventricular rhythm because it's still between 20 and 40. If this was a rate of 60, it would be accelerated idioventricular rhythm. And those are all of your ventricular dysrhythmias.